share my presentation with you. I will speak to you about biosurgery, which myself and many others feel that is probably the best horizon and future for our field of bone augmentation procedures, specifically in relationship to recombinant growth factors. I will share with you histological evidence of new bone formation, utilizing a composite graft to reconstruct the severely pneumatized maxillary sinus. First, in review, we know a whole bunch about recombinant platelet-derived growth factor. It's one of the best understood growth factors. It's completely synthetic, easy to use, excellent hard and soft tissue response. There's outstanding evidence, both clinical and histological evidence of periodontal regeneration for both interbony defects as well as now recession defects. And there are indeed many published emerging applications of off-labeled use for this growth factor. We understand the tissue engineering triad that we must have to form bone and soft tissue, appropriate cells, signaling molecules, bone grafting scaffolds, and sufficient time to end with regeneration. The addition of recombinant human growth factor, platelet-derived growth factor, transforms the appropriate matrice into an active graft, seeking specific cells needed for bone, soft tissue, and blood vessel formation. It's well-characterized protein that actively enhances connective tissue formation, bone regeneration, and angiogenesis. Naturally occurring, PDGF is the main growth factor in platelets. Other cells, such as macrophages and endothelial cells, secrete PDGF. Recombinantly produced, it is identical to the endogenous protein. In order to synthetically replicate PDGF, the amino acid sequence is extracted from the human gene and transplanted into yeast cells. As the yeast cells grow and multiply, the growth factor is produced. The growth factor is chemoattractant, causing cells such as osteoblasts, cementoblasts, gingival fibroblasts to rapidly migrate into the grafted defect site. PDGF is also a potent mitogen, causing cells to rapidly divide and multiply. The growth factor is angiogenic. Perhaps one of its most powerful applications is the fact that it will help with early bone and soft tissue regeneration through its influence upon angiogenesis. There's also research that we contributed to in regards to how PDGF affects early time points in healing, specifically affecting VEGF, the vascular endothelial growth factor, showing that it is active in the early stages of wound healing. One of the largest randomized prospective clinical trials we were involved with, combining recombinant platelet-derived growth factor with tricalcium phosphate in the interbony furcation defect. So we have strong clinical evidence of regeneration in the interbony furcation and now gingival recession type defects. There's much published literature in regards to this growth factor on label. Just some examples of adding this growth factor in an off-label application with allograft and xenografts in the human and animal models, with outstanding histological evidence of true periodontal regeneration in the interbony and furcation lesion. Further off-label publications with xenografts provide us intriguing thoughts of combining this growth factor and others to achieve regeneration beyond what we'd normally expect with more rapid healing. New histological findings from Nevin's group show things that we haven't really seen before. One of our speakers earlier mentioned BioOS being around at 12 years. Today we're seeing, with the addition of growth factors, BioOS resorption as early as 4 months. Here we're noticing reversal lines in the BioOS particle with a multinucleated giant cell involved with the resorption process. This is indeed new histological findings, and we must reconsider the normal path of healing with things like xenografts. Further off-label publications with allograft provide us more interest in seeing what other carriers are available for our recombinant growth factors. What I'll be focusing on is the reconstruction of the pneumatized maxillary sinus. We know that in order to compensate for this sinus bone loss, grafting is necessary. As we've seen with previous speakers, the membrane is reflected superiorly, allowing space for the graft to be incorporated, mature, allowing for implant placement. This procedure has much evidence. Multiple variables affect our success, and on meta-analysis that I'll come to in a moment, these are some of the things that affect our success: the type of the graft matrix, the length of the time between grafting and implant placement, the presence or absence of occlusal membranes over our lateral window, literature-based addition of bioactive signaling molecules to the graft, i.e. platelet-rich plasma, BMP2, and recombinant platelet-derived growth factor. A wonderful review by Wallace and Frum showing really how successful we can be with this technique and what things affect our success. We know that implants placed into the sinus, augmented sinus with particulate grafts such as anorganic bovine bone, show higher success rates than sinuses grafted with block grafts. 100% autogenous grafts or inclusion of autogenous bone as a component of a composite graft did not affect implant survival. Furthermore, implant rates were higher when a membrane was placed over our lateral window. The survival rates of implants placed into the lateral window technique range from 61, 61.7 to 100%, with an average survival of 92.6%. And what we all know today is that rough surface implants will be more successful than the machine surfaced implants. Another systematic review with many implants showing that in a 100% xenograft, we can achieve success rates up to 96%. Implant survival for composite grafts of autogenous particulate bone and xenograft, near 95%. Implant survival for 100% autogenous particulate grafts, a little bit lower at 87.7%. Similar results are shown in other studies by Hallman and Hissing. The length of time is what I really want to emphasize today between the graft and the implant placement. The duration between these procedures is dictated by the quantity and the quality of new bone regeneration during this interval. Dental literature is replete with studies examining the quantity and quality of bone regeneration at numerous time points. And in summary, most studies are small case series reporting percent vital bone formed as low as 19% at 3 to 4 months to 25 to 30% at 6 to 12 months. So if we're in that realm of 25 to 30%, we would feel quite confident with the long-term success of a sinus graft procedure. The majority of these studies include sinuses grafted with osteoinductive matrices such as anorganic bovine bone, mineralized allograft, and beta tricalcium phosphate. Currently, approximately 6 to 9 months are believed to be an appropriate time point between grafting and implant placement. Is it possible to significantly shorten treatment times when treating the deficient posterior maxilla by adding a recombinant growth factor to an osteoconductive matrix? A recently completed case series is what I will share with you today. 3 of 6 patients will be demonstrated for your viewing. This is a 50-50 composite graft of a xenograft and allograft combined with 1 unit of human recombinant growth factor, platelet-derived growth factor. You can see preoperatively we have a failing dentition in the maxillary posterior right quadrant. After extraction, we end up with a pneumatized maxillary sinus of approximately 3.5 millimeters in the second molar site. The sinus is grafted with the previously mentioned technique, and we end up with a sinus height of approximately 16.5 millimeters. During implant placement, cores were taken. 2 millimeter trephine was used to sample cores from the first and second molar site. First molar site being almost entirely in native bone. And we'll look at the histological evaluation of this. Really no surprises here, being that it's mostly native bone. We have healthy bone, well vascularized, and the type of bone we'd expect in the posterior maxilla, if not a little bit better type bone than we'd usually expect. When looking at our core from the second molar site at 4.5 months, we are noticing things that we'd certainly like to see with other histological samples at longer time points. This is by no means a completely mature graft, but we see bio-os particles as well as allograft particles surrounded by new bone, and on the surface of our new bone, signs of osteoid, in a higher power view of new bone formation with the very active graft still turning over into new bone. In this case, we can see the incorporation of our particles in new bone, feeling quite comfortable that whether the bio-os is resorbed or not, we have an osteoconductive scaffold with good new bone formation at early time points. And another view of the allograft being surrounded by new bone. And most importantly, 2-year post-implant success with favorable crestal bone levels and function under occlusal loads for 2 years. In summary, from grafting to implant placement was 4.5 months. Although the insertion torque elevated it, this implant manufacturer's torque wrench breaks at 25 Newton centimeters, so that was our minimal torque value at implant placement as well as at the time of stock abutment placement. Long-term follow-up, 2 years post-loading. In summary, this can certainly be argued by the histologist's review. What you'll see here is, first of all, Jeff, can I borrow your pointer? There it is, thank you. What you can see is that we've got in the native bone fairly good percent bone, and in the grafted bone as well, good percent bone. What can be debated here is the non-vital, that there's no allograft. This has been debated between myself and others and the histologists. They considered the allograft, because it was revascularized, they considered it vital bone, which this certainly could be debated. But really the bottom line is that in this sample here, we had 43% bone. In a second case, same graft material, 50-50 of allograft and xenograft with 1 unit of the platelet-derived growth factor. We can see a heavily pneumatized maxillary sinus with a mucus retention cyst, nearly less than 2 millimeters of bone in that first molar site. We handled this with ENT consult, verifying a patent osteomeatal complex and proceeding with our graft. And as you'll see postoperatively, we had nice resolution of our mucus retention cyst. Here's our post-grafting sinus augmentation, again with nice resolution of the mucus retention cyst and a nice amount of bone formed. This sample was subjected to a 3-dimensional analysis as well, showing favorable consolidation of the maxillary sinus augmentation. Before and after. And now we are showing an example of the trephines taken at the time of implant placement, implants placed in the bicuspid and molar regions, a second sample taken from the lateral window. Now looking at our histology at 3.5 months, a bit less mature, but as we look at this, we still are quite happy with the amount of new bone formed. New bone forming the xenograft, and as Dr. Nevins has shown, a well-incorporated piece of allograft that's been vascularized, but the rest, new bone surrounding. As you'll notice, our graft is still certainly under consolidation between implant placement and the time we uncover. Very active graft material with new bone and much osteoid on the surface. And other examples of both xenograft and allograft surrounded by new bone. And a very active graft around the small particles in our sinus. This is at provisionalization. After I had connected restorative abutments, the patient was provisionalized by the restorative dentist. And what's most important now to notice is the nice consolidation of our graft with a post-loading success of 1.5 years and favorable, stable crestal bone levels. Because of the failure in the upper right quadrant, we were also fortunate enough to obtain a cross-sectional analysis in the upper left quadrant post-loading. In summary here, grafting to implant placement was 3.5 months, same insertion torque value as well as abutment delivery values. using cement-retained abutments with a long-term follow-up of 1.5 years post-loading. Post-operative panoramic x-ray, this was the quadrant that failed next for us. And in summary, favorable healing, especially in the lateral window with 33% bone. We didn't have the best sample in the occlusal aspect of that. It was a much smaller sample than the lateral window. Bone considered to be 100% vital. Again, here, this could be debated by the review in that the fact that the allograft was vascularized, but it certainly wasn't new bone. Allograft particles still existed. And much more bioos still present at the time of our sample at 3.5 months. A final case for you, grafting to implant placement, in this case 5 months, same insertion torque and abutment delivery torque, and follow-up of 12 months post-grafting. This histology was most impressive to us because of the amount of bone formed around our particles at a relatively early time point. Fluorescent staining showing a very active osteoid around our particles, signaling that the maturation process is continuing. And under high power, another example of an allograft incorporated with new bone. Fluorescence here showing, or polarized, showing the new bone surrounding our particle. In 1 year post-restoration, maturation and stable crestal bone levels surrounding our implant-supported restoration. In summary, here at 5 months, core biopsies revealed 45% bone, 47% vital, 53% allograft, and 5% bioos. At 5 months, there is a significant amount of new bone formation with excellent integration between newly formed bone and residual xenograft and allograft particles. In final summary, this composite graft combined with recombinant growth factor revealed intriguing histology for favorable bone healing at early points of the maxillary sinus augmentation. Further research is absolutely warranted to provide adequate evidence for this composite graft technique. We do have, however, 1 to 2.5 year post-loading implant success in these documented cases. I thank you for your attention.
That concludes this program. This material was recorded and produced by Mobile Tape Company Incorporated of Valencia, California. More information about other available media may be obtained by calling 1-800-369-5718 or on our website, mobiletape.com.